Hi, everyone. Welcome to Life, Love, Insight, Fertility Experiences. Today I'm here with Arielle Bayer, Dr. Arielle Bayer, and she is at CCRM in Manhattan. And we're going to talk about infertility and like the 101 on what everybody would want to know when they're first going to a clinic. And I'm just so happy that you're here today. You know, it's such a delight to meet you. And we got to talk on a panel about PCOS, which of course is so significant in trying to conceive. So thank you so much for being here today.
Thank you so much for having me. I can't wait to talk to you all about this.
Oh, okay. So where do we start, really? Somebody comes into a fertility clinic because they haven't been able to conceive and they're nervous, and then they get to meet you. And what's the first thing? Like, how does this all start?
Yeah, it's a great question. I think that's the best thing to know before you come in is what to expect because I think it takes away a little bit of the fear and the nervousness and anxiety around it. The first time you come to a fertility clinic, whether you heard about it from friends or a doctor recommended you go, or you're just curious and it's something that you've sort of wanted to learn more about. The first time you come in, you'll sit down with a doctor like myself, a fertility doctor, and we'll just talk. So the first part of the visit is just talking, really getting a good history. The first thing I want to know is really what are your goals as an individual or as a couple if you come with a partner? What has been going on? What have been the struggles, and what are we trying to achieve? Is this your first pregnancy ever? Is this after coming in after multiple miscarriages or losses? Is this a secondary infertility, as we say it, looking to try to conceive for a second child or a sibling? Or is this like future fertility planning? So whatever the reason is, it could be anything under the sun. We're going to sit down for the first half hour or so to just really learn, get a lot of history from the patient and their partner if they're partners with them. The kind of Oh, I
Right,
lost you.
good question to say, what are your goals, right? Because a woman might be coming in because she's worried about fertility later on, in life, and she may just be looking to see if she should freeze her eggs. Or, somebody might be trying for the first time and really just wanted to have a baby, whether it's a solo mom or a couple. And then, it could be secondary infertility. So what a great question to ask.
Yeah, exactly. Everyone's coming from different walks of life, different backgrounds. And so, yes, I want to know how I can help them. We're here to help them navigate this journey, whatever the road may be. So we do a lot of talking in the beginning. I want to hear about not just their routine gynecological history and medical history, surgical history, all the things your doctors always ask, but it's a little bit more detailed. We ask about unusual gynecology symptoms. We ask super detailed questions about their menstrual cycle and what it's been like off birth control, on birth control, what kinds of birth control. We talk about the different like pain and pelvic pain symptoms they may have experienced, any more unusual gynecology symptoms that might be associated with PCOS or endometriosis. We touch on those. Would love to know if you know your mother's age of menopause or your maternal grandmother's age of menopause, understanding any female cancers in the family. So we dive into a lot of detailed questions for females, and then males get a full history taken as well. If you're with a male partner, we want to understand any of their medical history, their surgeries, any difficulty with ejaculation or erection, just anything that would be helpful to know, medications they're on, supplements they take, family history as well.
People must feel so heard when you do that.
We hope so. I want them to feel that way. You
I
know,
think so. After they do that, like after you have the initial consultation, you do any workups or any blood work or depending on what they want or what they have to say.
yeah, after we've finished the history taking portion, and if you're visiting in the office, it's not telemed. Of course, if it is telemed, we can schedule you to come in. But if the visit's in the office, it's best to complete the workup that day, and we can get a picture of what things look like. And for a woman, that would be like a baseline. We call it a baseline ultrasound to just see what's going on. Look at the uterus. Is there anything in the uterus that's obvious, like a fibroid or adenomyosis or any malformations, or what's the shape of the uterus look like? And also want to take a look at the ovaries. What are they showing? Where are you in your menstrual cycle? Does it sort of match appropriately what we should be seeing at that time of the month, in terms of The follicle count, we'll do a detailed follicle count to see, well, if you do need fertility treatment, if you do want to undergo an egg retrieval, what kind of numbers are we looking at here? What kind of egg availability is there per month? So we do ultrasound here in the office, and usually that's right at the same time as your first visit. And the blood work that we take, also done the same day, we'll get just the sort of basic workup initially, hormones, all the pituitary gland hormones that come from the brain, to sort of the ones that could interfere with one's menstrual cycle, like the thyroid hormones, prolactin. We'll get basic prenatal labs. If you're trying to establish a pregnancy, we want to make sure all your prenatal labs are looking great. And that's your immunities, your infectious disease labs, and also men too. I mean, there's two pieces to the puzzle. It's so important to get the men's blood work that day if they're available to be with the partner that day too. If the patients haven't done genetic screening yet from their OBGYN, we offer it at fertility offices too. So like at CCRM, if you came in, we can offer you genetic carrier screen. And that's to see if a couple is a match for any autosomal recessive gene disorders that they could potentially pass on to a child. So that's an important thing to do for any couple that's hoping to conceive.
Mhm. Wow, that sounds, it's really a lot. I think it's a lot for somebody to take in. So by the time they leave, it could be a lot of information. And then I think also when they leave, there's a list of things they have to think about and take home and kind of review.
Yeah, there's there are other big pieces of the fertility workup that don't happen that first day they come in. One of those things is the semen analysis for the male. It is something that I don't want to spring on the partner right away and say, oh, you have to go do your semen analysis right now. It's a little bit of pressure. So I usually schedule them to come back and do that at a time that works with their schedule. We often ask for about, 1 to 5 days of abstinence before coming back in. So that's something that they can schedule on their own time. But that's a really important part of it, is the male portion of fertility, because it can contribute to, up to 30% of couples will have just a male factor alone. And then also for the female, if they're having difficulty conceiving, it's so important to do a fallopian tube test and a uterine cavity assessment. And that's a study called an HSG exam, or hysterosalpingogram. It is a separate test that not every clinic might have it in the office. They may send you to a radiology suite to have it done. And that's really to make sure that there's no blockage of the fallopian tubes. There's nothing like a mass or a big polyp in the middle of the uterine cavity or scar tissue that could be blocking a pregnancy. So there's several other items that will send them home as a to-do list. But we always want to finish the appointment with sort of a summary wrap up with, for example, a patient care coordinator or someone to kind of summarize everything we talked about, make sure that they have an action plan of next steps, and also to set a follow-up, because that first visit is a lot, like you said.
It's a
We can't
lot.
always get to everything in one visit, and it's also not everything registers. We may have talked about a lot of things, but we need to revisit. So a follow-up appointment, just to be able to kind of regroup, reconnect, go over what we have sort of summarized so far, is really important to do.
And no, it's a huge amount of information, and they still have to deal with the financial piece of it as well. So the case manager is so essential in the clinic in those ways. So you mentioned a couple of things that, people they get their screening, and when they go for the initial screening, right? So often I hear that people get fibroids, and the fibroids could interfere with being able to carry, and so they have to have they have to have the fibroids removed. And then you were talking about fallopian tubes, and sometimes that creates a little bit of an issue. Not always, it's not standard. And so that could be a point also where possibly there's a little bit of a delay, that people have to go for a little bit more of a screening or a test. And those aren't even the main reasons for people going to you.
Right. Right. So fibroids or fallopian tube blockage, those are definitely can be causes of infertility. I would say some of the big causes of infertility that we see often, like I mentioned already, is male factor infertility, just either a low sperm count or low sperm motility, something that is either has to be investigated further by seeing a male reproductive urologist, or a reproductive specialist for men. Go
Yeah,
ahead. Sorry.
it's a female infertility. Like it's really equal balance there. It's not like female is more prevalent than male. They're kind of 50-50 in terms of splitting that, you
It
know?
really is. Yeah.
And then we have the unexplained infertility, just so anyway, I'm sorry, I took you off track. But let me let you go back on track.
Oh, yes. So that could be, that is one of, a large cause of a common cause of infertility, and it is a 50-50 split. So that is one we see often. Another one we see often is a woman having irregular cycles, or her body isn't ovulating on its own. This is called anovulation or ovulatory disorder fertility. It could be from a disorder like PCOS, right? And that can be seen on ultrasound and with lab work and history taking. That is another big cause, is a woman just needs, her body needs some assistance in actually growing and releasing that egg each month to get pregnant. Yeah. And other reasons, endometriosis, we see often on ultrasound or through a good detailed history taking can be established. And it's a very, very difficult to diagnose disorder, because so many women are misdiagnosed or non-diagnosed with this. So that is definitely something that I see a lot.
But these things can still allow you to become pregnant because there are treatments.
Yeah. So what the first part of coming into a fertility office is hopefully to get some answers and to kind of give us a way to move forward and to seek out the best fertility treatment that's going to help them. Whether if it's ovulation disorder, we have a way to help the woman ovulate. If it's a semen analysis issue, a male factor fertility, we have, fertility treatments to overcome that as well. Like you said, sometimes we get that diagnosis of unexplained infertility, which is so, so hard and difficult. And sometimes what I think when I get a diagnosis of that, or a patient comes to us with that presumed diagnosis, I say, let's turn over every stone. Let's really investigate and look deep here. What are some things we haven't figured out yet or not investigated yet? Because maybe we just haven't been looking, detailed enough into what's going on. Is there some sort of, it's a difficult diagnosis, because as doctors, we always want to have an answer. The patient wants an answer. We need something to help them. So often I always say, let's take a look at this with fresh eyes. Maybe something was missed, and let's keep looking.
Yeah. So when there are diagnoses, it's very hard, and it's hard to cope with an unexplained one. I think for the doctor as well as the patient, because the patient really struggles with it, and the doctor really wants to find the answer. And so then there's so many other workups and tests. And lots of times people will go for different types of treatment when they're first you know, getting to a reproductive endocrinologist. So if they're trying to conceive and the fallopian tubes are clear and the uterus is clear and everything looks good, but maybe they need a little help ovulating, there's different types of medications and drugs that doctors prescribe to help them to move things along, or there's different ways of conceiving besides just timed intercourse or just natural ways. So I wonder if you could speak to that just a little bit.
Sure. So, in terms of different things, patients may come in doing all the alternative therapies, or more just what are different options of
Things I think, and alternative treatment is an option, but typically, I don't know, I could be wrong, but most of the doctors who I've worked with are a little leery, and the acupuncturists as well, of herbs when trying to conceive, because herbs are medicine, even though they're herbs. So most doctors I've found that, but certainly I defer to you.
Yeah. So exactly. I think that it's so important to see a fertility specialist and someone who's a board certified, trained reproductive endocrinologist and infertility specialist, because there's definitely patients who will come to us with ideas or things they've read online, things that they've heard about, and it's important to be open to these ideas. I want them to tell me what they're thinking of, what they've been presented with. I want to try to understand, where they saw this, and try to work with them on it. But we really truly believe in evidence-based medicine and making sure that whatever treatment path we take has the evidence behind it, that it's not going to, one, harm them, absolutely should not harm them or cause any harm to them, but that there should be some evidence that it's going to help and benefit them. So I think yes, it's something that you really have to have an open conversation, open dialogue with your doctor about if you're going to do an alternative therapy or something that's a little bit off the beaten path of fertility treatment. Within the realm of fertility treatments, it's not one size fits all. It's not just like everyone go do IVF. We have lots and lots of options to help patients conceive. Whether it's for the female or the male or for both of them, it could be as least in the sort of from the least invasive end of the spectrum, like timed intercourse you mentioned, really helping the couple understand the best time to have intercourse. It sounds self-explanatory, but it takes a little bit of monitoring, investigating, really examining what's like, when is ovulation about to happen? Do we need to help them ovulate and provide that ovulation trigger shot? There's also a little bit more invasive, but still on that sort of ovulation induction spectrum of helping a woman ovulate, tracking her ovulation, helping her with ovulation with a trigger shot, but then doing an intrauterine insemination. And so that's a process where the sperm is actually washed in a sperm wash in the clinic, and it's brought down to a very small concentrated amount of liquid, and it's put directly into the woman's uterus in the office. So we actually help people conceive that way. So this is a really good option for couples who are using donor sperm or who have mild male factor infertility, or there are couples who, for timing reasons, work, travel, life can't be intimate at the time that they want. So this is just a way to try to overcome some of those barriers.
That's great. So the IUI is something that's less invasive and a little bit easier, and the timed intercourse. So I'm thinking of all the anxiety that goes along with timed intercourse and the watches, and I once had a woman say to me that she would hang from a chandelier just to get her husband to have sex because it changes life so much when you have to pay attention, and everything now becomes a different focus and a different emphasis. But there's medical research behind it. And so I'm so glad that you mentioned that, because it's important to know, and it's important to recognize that the ovulation kits and the ovulation apps and all of these other things are there to help, and hopefully do. I'm not sure how much they help, but I'd have.
I know it's tricky. I feel like a lot of that things that are trying to make life easier at home, like track this at home, track on your watch, on your ring, on your app, it often causes some more unnecessary anxiety and more stress. And at the fertility clinic, we want to take that stress out of the picture. We want to say, hey, let us do that work for you. Let us tell you, to take that burden off of your own shoulders, when to have sex or when to do the IUI. So, I think we try to take the stress out of it by helping assist with those really stressful decisions.
Yeah,
All of this can cause undue anxiety.
right. And this is for heterosexual couples. So
Correct.
I think it's also really important for heterosexual couples who are having time intercourse to know that the sperm lives in the body more than just a day. So if it's a little bit off, it's okay. If you want to go out to dinner first or what have you, you can do that.
Correct. Even up to 5 days, I say, if you don't have to try to have intercourse every single day. If you do it every 2 to 3 days, the sperm should be living in the reproductive tract for that amount of time. It should be fine. So we try to give a little flexibility there with timed intercourse.
And then when somebody kind of doesn't conceive this way, either through, timed intercourse or through an IUI, then they have to move on.
Correct. There's some couples who or individuals who will need to move towards the IVF for fertility treatment because this isn't a valid option for them, or is not going to give them much improved success or benefit. Or there's couples who have already tried that way and it didn't work for them. So IVF, or in vitro fertilization, is just a more advanced fertility treatment that is at least a little. It is more invasive of the body. You're giving yourself medications with injections. You're being monitored frequently in the clinic a little bit more often, and you're putting yourself through almost 2 weeks of treatment that culminates in an egg retrieval. So you're going to be under anesthesia and undergoing a minimally invasive procedure. It's more costly. uses more time, resources. Insurance doesn't always cover it. Everyone's plans are different. But in terms of efficiency of reproduction, it's our best way to try to maximize your chances within 1 month cycle.
Yeah. I was going to ask you if there was any information about like what would work best for, because the big ones or the big diagnoses really you hear about so much of the PCOS or the endometriosis or I don't know which others would be top of the list for in terms of people who are
Yeah,
coming.
I think when I think of the patients who would benefit the most from IVF right away is the patients who have severe male factor infertility, who the IUI and the sperm wash wouldn't provide much benefit for. Women who either are anovulatory or have PCOS and they've already failed the several cycles of, or maybe don't respond to the available ovulation induction medications, sometimes ultimately end up at the IVF route. Endometriosis is a tricky one. It often affects not just the number of eggs available each month, but it can also affect the quality of the eggs. It can lower egg quality. So maximizing your chances with as many tries with IVF essentially takes all of the available eggs out you have that month and tries to create an embryo and create a pregnancy that way. That's oftentimes the best option for women with endometriosis. And if your tubes are blocked, if you do have a fallopian tube infertility diagnosis, then or you don't have fallopian tubes, you've already had your tubes removed from an ectopic pregnancy, for example, then IVF is the only way to establish a pregnancy because you can't conceive using your fallopian tubes.
Oh, thank you for explaining that. I appreciate it. I'm sure everybody appreciates it. And so I think I have one more question to ask you, and I don't mean to put you on the spot. So if I am, tell me. But do you think most people get pregnant when they're trying to conceive?
So no, I think that, for very young patients who have really young eggs and higher quality oocytes and no infertility, yes, there are you know, you hear the stories, oh, I conceived on my first try, but majority of couples do not. It is just not true. So it often takes, 6 months plus, it could take 12 months for many couples. But I think if you know that there's something already in your history. You already know that you've had a history of a pelvic inflammatory disease. You have a history of endometriosis. You know you have PCOS. There's a male patient who had a, chemotherapy or, some sort of surgery, hurt, of the testicles as a child, whatever the case may be. If there's something already known, seeing a fertility doctor sooner than later is always just the best option, I think, to look into this earlier than just giving it a year of trying.
So if there's a known reason, don't wait a year. And if you're over like 35, don't wait a year. And even if you're under 35 and you know that there's something going on, don't wait a year. You don't need to. Yeah.
Right. And exactly. And I think sometimes as you talk about the anxiety piece, when you are, hoping to become parents, and this is sort of that seed's already in your mind and you want to conceive, every single month you're trying can feel like a year. It could feel like way longer than waiting for that pregnancy test and waiting those 2 week wait. It's the worst. And so, you know, to suffer through the full 6 months, after age 35 or the full 12 months before age 35, I think is not taking into account the sort of mental and emotional and psychological impact that trying to conceive can have on a person. So I always encourage a couple to come or an individual to come see us when they're ready, as soon as they're ready.
Yeah, I love that actually, because it makes sense. There's so much stress associated with it when people are trying to conceive and they're not, and so it's wonderful. And why wait?
I didn't mention also the sort of the genetics is a big part of it too. If there's a known hereditary disorder for a breast cancer gene, a colon cancer gene, something else that runs in your family, or that you found out with your partner, you're a carrier for the same autosomal recessive conditions. So that's something like sickle cell anemia, cystic fibrosis, those ones. It is best to talk to a fertility doctor because we have options for those patients. We have options to create embryos and to find which ones aren't carriers of those conditions. So that's another reason that couples sometimes come straight for IVF when they come to see us.
Yeah. Okay, great. No, I think that's great. I do tend to like to believe that most people can have a family. Sometimes, you're not sure how you're going to have the family, or you have to go through so much to have your family because it's not easy. It's not easy. It takes such a toll emotionally and physically and socially and financially. And it's so wonderful that there are trained doctors like yourself to be able to assist through that process. So thank you. It sounds like the first meeting is so revealing and so significant and just helpful, and engaging.
And I hope that the first visit takes some of that burden off the patient, right? It gives us some actionable steps to take, gives us hopefully some answers. We might not have the answers right away. It might require a little bit more investigation. We have couples who come in who are getting pregnant but have recurrent losses again and again. And so those require certain different kinds of blood tests. We're looking for a little bit of a different reason why that's happening to them. It could be just age related, aneuploidy, meaning their pregnancies are not normal chromosomes. And that's just a factor of age, never their fault, never, they didn't do anything to cause it. Just that's what happens with our eggs as we age. So I think that, each person's individual reason for coming to see us will lead us down different paths to look. But we want that first visit to try to remove some of the burden and the distress and the anxiety and try to help them just take those initial steps of the journey.
Well, it sounds like you're doing everything you can to do that. It really does, to spend that much time too. It's wonderful. I don't know if that's standard practice. I hope it is.
I hope so too. And I think speaking like with someone like yourself too, I think that should also be part of that first step is to, if they don't have a therapist or someone they can speak to about what they're going through, I think that's really good to try to connect them with someone early on in this journey, because it could be a quick journey, it could be a long journey. And sometimes there can be, stress in the relationship from all of this, stress that the person's blaming themselves or feeling down on themselves and feeling responsible, and they're not. Um, so
Yeah,
it's important.
the longer it goes on, right? If you're trying to conceive and it doesn't take that long, then it's typically enough. But this is a medical diagnosis, and medical diagnoses cause anxiety and sadness, sometimes depression, and that's normal. That's typical. And then you start to isolate. And so if you have a partner, if you change this communication, if you don't have a partner, you can change your socialization. So it has a big impact depending on how long we go. So I appreciate you saying that. It's really an important piece. It really is. Couples with the medical, you really want to work as a team together. There's support groups and there's workshops, there's things out there. And, I so appreciate you coming on today, to talk about this. I think it's such important information. And people have apprehension. They don't know what to expect when they go to a clinic the first time. And they don't really have this 101 on what infertility really is. So this is fabulous. Thank you so much.
You're welcome. I hope this was helpful and happy to, do any other conversations you'd like to have about this topic. I think we could talk for hours about it, but just the initial visit, I think, is something to kind of take that, demystify it and make it more approachable so that people aren't nervous to come in.
Yeah. Yeah, no, I think it's so important. It really is. So thank you so much. And if somebody ever wanted to get a hold of you, how would they do that?
So the best way to get a hold of me is to reach out to the CCRM New York Fertility Office. You can find us on the website, CCRM. I think it's ccrmivf.com. I should probably know that. But if you Google Dr. Arielle Bayer or CCRM New York, you can make an initial visit with myself or any of my partners. We have 4 doctors in our practice. We're all happy to see any of you anytime.
Well, thank you so much. And if anybody has any questions, they can always reach out to me at lorinets.net. Thank you.
All right. Thanks, Lori.
Okay, I'm going to stop the recording now.